ago when Harvey Cushing started brain tumor and described a classification which is still, if you look at this, it was very clever considering the tools he had at that time to establish a classification of brain tumor. He was very, very insightful. Now, today we say this is not relevant, but for doing this, he had only just this tool, which was a microscope, a tool that was invented in the 1700th century. And of course, we need better tools. And particularly with the notion that there have been a lot of advance, particularly in genomics, the question is how do we integrate this knowledge into our classification? And there have been a number of books of CNS tumor in the adult and pediatric population that have tried to integrate this knowledge. But I want to take a quick example. You know, ependymoma. If you talk to ependymoma specialists, this is a topic with a lot of debate and tension. And as illustrated, there are two types of ependymoma, benign and anaplastic. But if you look at clinical trial, you can see that there are huge differences, even if the kids, the criteria for recruitment are exactly the same. And one work illustrates this difficulty to agree on what we see and what we try to assess visually is this paper where there were 5 pathologists to try just to look at the same slide, and they agree the day before. They had a big meal, you know, they were happy at the end of the day. They agree on the definition of benign and anaplastic. And the next day, everyone, you know, looked at the slide, and you can see that there was only 50% of consensus between the different specialists, regardless of the clinical trials they were looking at. So it really illustrates that the eye is not enough. And the question is, can we do the same that has been achieved in leukemia, where there is a classification for treatment purpose with very, very good tool to allocate treatment. And for this, you know, there is a tool or there is a system or philosophy which is the integrated genomics, where you take all the genomic information, all the information you collect, you put it together, and ideally you know exactly what you are talking about. And what is important here, you don't have to rely on the eye, you rely on the result of a test, which is done by a machine or a tool. And if you do this properly, you can just develop some specific classes based on the gene expression, the DNA methylation, and then you can just either predict outcome or allocate treatment. And certainly one of the big tools is the gene expression, and using this to avoid any conflict or to avoid any discrepancy. Oh, sorry. To avoid any discrepancy, so this is done by a computer and using the technique called hierarchical clustering. And one clear example of this is what we call DNA methylation. So the methylation is, you know, a chemical process by which you add a radical methyl on the adenosine or cytosine, and it changes the expression of the gene. And we have 22,000 genes, so you can imagine that the tool that you use is very sophisticated. One of the best tools is the Illumina, which is a 450 or 850 array. And this is what is done at the level of a tumor. You can see hypermethylated or hypomethylated area in the tumor cells. And at the end, it gives you this cloud. And according to the position of the tumor in the cloud, you can define different groups. So that's what we use the methylation. And in addition, it gives you some information about the gene, about the chromosome loss and chromosome gain. And with this, you can allocate or just say this is this type of tumor and this type of tumor. And as an illustration, one work that has been done, which has been a fantastic work, was to try just to figure out what is the term of PNET, S-PNET, supratentorial PNET, does it look like? And they did methylation, and this is the team in Heidelberg, they did methylation, and they could see that, you know, there was a cloud of different type of tumor, and you can see that they could eventually give a name to each of, you know, the cloud they could see here. And some were indeed PNET, but very few, in fact. Some were rhabdoid tumors, some were ependymoma, and also they could identify some new category based on the methylation profile. For example, this FOX2R, or the AGNet BCOR, or the AGNet MN1, which were a new category of tumor. So, and this has been done eventually for all brain tumor, and this is how the pediatric brain tumor look like now. This is a big, you know, sky or cloud, and depending of where it is, there is a name that is given to the brain tumor. And there is now, many people are using what we call the Heidelberg classifier. So we put a tumor into the methylation system, Illumina often, and we compare the result to this one, and depending of where the tumor is, you don't even need a pathologist. I don't want to say you should throw the pathologist to the bin, because if the tumor is outside the cloud, you are in trouble. So that's the technique that we are using right now. And we add also, we can add some more information. For example, we can add copy number data, and this helps to refine what the information we get from the methylation. So as a sort of summary, so these are the tools that we use for classification. Also, we can add amplification, deletion information, point mutation, or translocation and fusion. All this material has been developed over the last 20 years, and this has completely changed the landscape. And how does it apply to the subgroup? So when you do this in medulloblastoma, which in the past was one tumor, and we knew some distinction in the pathology. There was a classic, there was a desmoplastic, there was an anaplastic, but that's all. So the people have used either relatively limited series, 50 or 70 patients, 100, and finally a very large series, and that's the Toronto work on 1,200 tumors, to reach a consensus. And this is a consensus that has been reached with, there are 4 different families of medulloblastoma. The WNT, which is essentially adolescent and adult. Sonic Hedgehog, which is baby, essentially baby and adult. Group 3, which is mostly baby and children. And group 4, which is all ages. And with some clinical characteristic, some genetic characteristic, and some characteristic gene expression profile. So this was really a very, very big step to try to identify. And what also was looked at, we looked at the tumor at the time of recurrence when we had some sample, and we saw that the subgroup was stable. There was no change of the subgroup at the time of recurrence. And of course, what we wanted to know is whether some prognostic factor that were in the last 40 years could be integrated into the classification. So we have reanalyzed this in the context of a number of medulloblastoma, and for example, the chromosome gain or loss were integrated. And I want you to follow this, because there was, for example, the identification that chromosome isochromosome 17q was a bad prognostic marker, but in some series it was not a bad prognostic marker. Integrating the subgroup, you can see that this is a bad prognostic marker in group 3, but this has no meaning in group 4. So you have to integrate this into the subgrouping. The same with chromosome 6 loss. Some people say it's a good prognostic marker, some people say it doesn't matter. And when you look at when the patient has a Wnt tumor, this is a very good risk marker, 100% survival. When the patient doesn't have a Wnt tumor, it has absolutely no impact on the outcome. So very important to integrate additional information in this context. And that's a list of examples. For example, TP53 mutation, which is a very bad marker in sonic hedgehog, very bad marker, has no meaning in Wnt. This is a good prognostic marker. So don't rely on P53 staining only. You need always to integrate P53 in the context of the subgrouping. And so this has really changed the way we treat medulloblastoma, and we need for this just a new approach, risk stratification based on this. And in fact, this was a model that eventually was applied to glioma, high-grade glioma, to ependymoma with 9 different subgroups, and looking at the same approach and trying to integrate information. But more than this, within medulloblastoma, some people try to do some more, research and identify, for example, that in the sonic hedgehog, there was not only 1 sonic hedgehog, but 4 sonic hedgehog. And in ependymoma, in the posterior fossa, there are 3 types. Essentially, the dominant are PFA and PFB. The PFA are the ependymoma of the little kids. When you look at the ependymoma of the posterior fossa, you have 9 different subgroups. So for us clinicians, it becomes a nightmare and it becomes much too complicated, but it may have implication in terms of management in the future. So really, this provides the opportunity for accurate diagnosis, for more precise risk classification, should we irradiate or not, and perhaps for potential drug target, but also for researchers to develop some preclinical models. So how do we apply this clinically when we don't have the tool? Some people have started to develop some immunohistochemistry, including for the subgrouping of medulloblastoma, and at least we can also eliminate by using immunohistochemistry some of the diagnosis. But I want to come back to the medulloblastoma. I told you there are 4 subgroups of sonic hedgehog. But when you look at the infant, in fact, you have 3 subgroups, sonic hedgehog B, gamma, beta, gamma, and group 3, essentially in infant. And very, very few group 4. But this is a work we have done using high-dose chemotherapy in Toronto and shown that the sonic hedgehog have a very good outcome, and the yellow, the group 3, have a more guarded outcome. The group 4 were very, very few in this work. And in a similar study using less intensive chemotherapy with lower result, the Sanjut team identified the same pattern, but also they could divide the sonic hedgehog into 2 groups. So that's how we really realized that there were 2 different sonic hedgehog medulloblastoma in infant, one called 2, which is better, it's the blue, and one called 1, which is more aggressive. Interestingly, both have on histology a desmoplastic histology. So you cannot see this with your eyes. You need to have, methylation to do this. And this is the result. So the protocol for medulloblastoma in infant, which was very straightforward and based on the pathology, is becoming now much more refined and sophisticated using methylation data. And the same for all the patients, so you may still have in mind that we classify in average risk and high risk based on dissemination and extent of surgery. This is a new classification of medulloblastoma in older children based on the 4 groups, but also based on some molecular characteristics with a number of boxes. Of course, it's becoming more complex, but with this, we can make very clear progress in the treatment. And the same is happening in high-grade glioma, where we have identified some alteration, and we are now able to classify according to some gene expression profile. Of course, this is becoming so complex in low-grade glioma as well, and where we have to, we are using a different approach by eliminating, for example, some alteration and progressing into a classification. So the same is also the case in rhabdoid tumor, where it's a bit less clear whether there is a prognostic influence or a treatment impact, because we still treat rhabdoid tumor the same way, even if we have identified that the sonic drug may be a bit better than the two other categories. But it provides also some opportunity, because we have identified target for specific treatment. And so this is something which is new, and we can expect the next generation of protocol to integrate some provided from the lab. Same in pineoblastoma, very rare tumor, 1% of the brain tumor, but fantastic work done by Annie Young from Toronto. She identified 5 different subgroups, including the retinoblastoma, so from which we are going to hear later on. The RB has a specific profile. It's a very bad prognostic, but you can see that the subgroup 2, which is often associated with DICER, 13% representing the pineoblastoma in the teenager often have a 100% survival. Following this work in Toronto, we have decided to have a collaborative work worldwide, and it has confirmed the data that we have first reported in the Toronto experience. It also, this type of approach allows us to have a different look at the patient, because we know that a number of patients have predisposing condition, and depending on what we see, we can then have a sort of automatic process by which we would say, of course, low-grade glioma, we always look for catheter spots, but if you have an IDH1 mutation, you should be screened for MMRD. I will come back later in my next talk, or leave for a minute. So that's very important. Or if you have a medulloblastoma sonic of an infant, you should look for Golin or for SUFU, which is a predisposing syndrome, or WINT, you need to look for APC. So a number of things that can trigger, some research for a predisposing condition. The very exciting thing, which really mimics leukemia development, is we are now using this tool that I mentioned initially to look for minimal residual disease. And so this is some work that we did with St. Jude in the St. Jude protocol. We are part of it, where you look at the MMRD, looking at the CSF, and you look in the CSF, the same expression that we see in the tumor. Initially, very little meaning, so that's before the radiation. But after the radiation, you can see the two curves separate, and by the end of treatment, the MRD in the CSF become highly significant. So we can expect that in a few years from now, you will not even need an MRI scan. You do a lumbar puncture and you look for residual disease or cell-free DNA. And so this is coming. We are using circulating CNA from the cerebrospinal fluid, not only for subgrouping, but also for residual disease. So you can see that there is a big change, which has made pediatric brain tumor much more heterogeneous. But we understand much better, why patients are successfully treated or why they fail. And of course, it doesn't increase the cure rate, but it gives us a better tool to better treat our patients. Okay, and so that's the last slide to illustrate that, that's the clinician here. They have always been slow, and that's the research on the right. So what we need to do together is to make sure that we are on the same plane. And so that's my role here to advocate, and I have been part of a team of great researchers, Michael Taylor, Vijay Ramaswamy, and people like this, And we have tried to work together in Toronto just to bring the clinician and the researcher together to make this happen. So I thank you for your attention. Happy to answer any question.
Yeah, a question in the end of the session, Dr. Arif. I don't know if Dr. Abir with us online.
Bismillah wa salatu wa salamu ala Rasulullah. I'm privileged and honored to present our next speaker, Dr. Abir Al-Battashi. She will join us virtually from Oman. She is a consultant pediatric oncologist at the Royal Hospital of Oman, head of pediatric hematology and oncology, pediatric consultant pediatric neuro-oncologist. Again. Bismillah wa salatu wa salamu ala Rasulullah. I'm privileged and honored to present our next speaker from Oman, Dr. Abir Al-Battashi. She will join us virtually. She is a consultant pediatric oncologist at the Royal Hospital of Oman. She is head of pediatric hematology and oncology, pediatric consultant uro-oncologist of National Oncology Center of Muscat. She finished her clinical fellowship in pediatric hemato-oncology in Birmingham Children's Hospital, UK. She will join us virtually. Are you ready?
Hello?
Yes, Dr. Abir, do you hear us?
Good afternoon. Actually, I'm unable to share my slides.
Just give us a minute, we will try. Dr. Abir, do you hear us?
Yes, I can hear you. Actually, I will just share my slides. So, good afternoon, everyone.
Good afternoon. The floor is yours.
I hope you can hear me well.
Yes, yes. And the slides are.
Yes. Yes. So, good afternoon, everybody. Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Dr. Abir Al-Battashi, and who doesn't know me, actually, I'm a pediatric oncologist and a neuro-oncologist back in Oman, and unfortunately, I couldn't make it physically there to the conference today, but I'm really grateful for giving me this virtual opportunity to present some information about pediatric low-grade glioma, which is it's actually one of the burning neuro-oncological or pediatric neuro-oncological aspects. Prof. Buffet actually has shared a lot already, and I'm just following up to whatever he has shared with us. So, so my topic actually today, or my presentation, is aimed to answer the big question, which is, does one treatment fit all patients? And I'm here mainly focusing on the conventional treatment for pediatric low-grade glioma, and I'm going to share basically some experience from mine, like for the last 5 years here in Oman. So pediatric low-grade gliomas are actually the most common childhood brain tumors. They account for almost 40% worldwide. And as per the WHO, these tumors are categorized into grade 1 and grade 2 gliomas. And I do like this definition where it says that these are heterogeneous group of neoplasms that encompass tumors of primarily glial histology, including astrocytic, oligodendroglial, and tumors of mixed neuroglial morphology. In the West, these cases account for 14 cases per million, and the main reason for death in pediatric low-grade glioma is actually primary progression. We here in Oman, we get around 8 to 10 cases per year. So in the Sultanate, we are almost 4 million, our population. We are almost reaching there. So we are a growing population. And every year I get around 8 to 10 cases per year. It's not a true reflection because many patients actually travel for treatment abroad. However, this is the actual number that I receive every year. The average age of presentation is around 2 years, 8 months. The youngest patient that I had was 1 month old. And equal female and male ratio. The majority are posterior fossa pilocytic astros, with the followed by optic pathway glioma, mainly in NF1 patients, either genetically confirmed or phenotypically they are fulfilling the criteria for NF1. Other patient had other locations, including one spinal pilocytic astrocytoma who is fully resected and doing very well. So surgery, so basically the survival in low-grade gliomas in children is generally excellent. And as Prof. Buffet mentioned, these are chronic diseases. So patients live with it. And this is a very important aspect when you handle these patients for the first time or you counsel them when they first present to you. That some of these tumors, especially patients with residuals or incompletely resected, optic pathway gliomas, these patients actually live with these tumors. So we are handling chronic illnesses in these patients. And these are slow growing and may have protracted periods of growth arrest over the patient's lifespan. And in some, like in papers, they mentioned that they live and die with the person actually. The prognosis is influenced by many factors, including the degree of tumor resection. So surgical resection is a very important prognostic factor. The histology and molecular tumor classification, in other words, the biology, and whether there is any dissemination or not. And the presence of diencephalic syndrome is associated actually with a poor prognosis. So diencephalic syndrome is a hypermetabolic state that happens in infants with suprasellar pineal low-grade gliomas. And usually whatever calories you pump in these infants, they never grow, they never gain the weight, they have large head size, they look sick and cachectic. Cure rates are over 90% worldwide for low-grade gliomas, especially for cases where tumor has been totally excised. And as I mentioned, these tumors usually happen in isolation or occur in isolation, but metastasis is a possibility, especially in 5 to 10% in some reported cases. Like in my patients, I have 52 low-grade gliomas and I have only 2 patients with metastasis or multifocal disease, in other words. Are these patients genetically predisposed? Yes. So as we mentioned before, NF1 is a major predisposition because of the genetic pathway in low-grade glioma, and they account for 10 to 20% of pediatric low-grade glioma. Tuberous sclerosis complex is also associated with SIGA, or subependymal giant cell astrocytoma, and this MRI that I put here is very typical for a SIGA, actually, at the floor of the third ventricle. Usually patients are asymptomatic. Many TS patients are picked up on screening. However, they can present with headache, with acute or obstructive hydrocephalus, and palsies, actually. However, majority are asymptomatic and don't require any intervention. So the WHO actually has re-revised the classification for CNS tumors in general in 2021. And it's a very interesting paper, and I really enjoy reading it, actually. I've learned a lot, actually, from the experience in other countries and institutes. So basically, they advocate for a layered diagnosis. And that means that the pathologist or the neuropathologist need to include the molecular information, the histopathological classification, and the tumor grade when they give us the pathology report. And it's quite extensive, but for pediatric low-grade gliomas, they mentioned that either within pediatric type diffuse low-grade gliomas, which we're going to go through later, circumscribed astrocytic gliomas, and glioneuronals and other neuronal tumors. And it's quite extensive, and I also advise you guys to go through this paper. It's amazing. So when we approach patients with low-grade gliomas in our setup here in Oman at least, so we look into the initial referral, how patients present to us. Many of these patients come through the ophthalmologist or optician, and a few of them come through the neurosurgeons actually. And it has been a great improvement because neurosurgeons now, they don't jump into operating optic pathway gliomas anymore. Actually, they do refer to us, and we do have a better communication over the last few years. So when you evaluate these patients, you need to look into the neurological aspect, clinical and history-wise, the ophthalmological assessment, and the biology of the tumor. We are not just saying the pathology, actually the biology of the tumor. And an important aspect for me, at least here in Oman, is to look into the socioeconomic situation in these families, because many families come from faraway areas, from rural areas, mountain areas, where access to therapy, emergency care can be very difficult. Some families actually have a low income where every day really matters. And some of these treatment protocols advocate for weekly therapy. This is very devastating for these families. I've got so many delayed diagnoses and interventions because of these challenges in these families. And also families with NF1, where so many children they do have NF1 and optic pathway glioma. For parents to manage that is very difficult for them. As we know, it's really proven, and there is a lot of literature about the association between the socio-economic situation of the family and the outcome in childhood cancer. The poorer or the low it is, the poorer the outcome in general. So briefly about the neurological assessment that we do, we look into signs of headache, nausea, vomiting, or basically raised ICP. We look for signs of diencephalic syndrome in infants in case there are any seizures, whether history or clinically, ataxia and incoordination as CFS symptoms, and brainstem signs and symptoms also. We look for cranial nerve pulses, and we look also for endocrinopathies in these patients. And when we examine them, we look for neurocutaneous features for the diagnosis of NF or the tuberous sclerosis complex. And then we interpret the ophthalmological report, and this is another challenge that I faced when I started the neuro-oncology service here in Oman, is that ophthalmologists didn't really appreciate the importance of the visual acuity that they were doing. So even the follow-up was not timely for these patients. They just see them at diagnosis and that's it. So children are very challenging, and they need a proper pediatric ophthalmologist to assess them and to perform appropriate visual acuity tests or methods in these patients, because this is the most important aspect when you decide whether you're going to treat or not. For me, it's superior to the MRI, especially in NF1 cases. So you need a reliable and objective testing results and follow-up. And the infants are a specific high-risk group of patients because these patients tend to lose their vision, and the assessment in them can be totally unreliable or very difficult, actually. So the histopathology, So the tumor biology here is the third aspect that we look into when we evaluate these patients. We look into the histological classification and if we got any molecular testing. Here in Oman, we don't have it established yet, but we are collaborating with centers abroad where we can send unstraightforward patients for testing, whether FISH, NGS, or methylation testing. So here we look into or associate the known pathological entities with common molecular or genetic alterations. And indirectly, these genetic alterations diagnose these patients for us. So maybe one day we don't need pathologists anymore, not to underestimate them, but actually the genetic testing here is superior to the conformal or the normal pathological assessment in these patients. So for example, pilocytic astros are associated with the KIA 1549 BRAF alteration in almost 80% of the cases. So this is diagnostic. There are, of course, many others. Less commonly, actually, the BRAF V600E. The SIGA, as we know, is associated with the TSC1 and 2, and the diffuse astrocytomas are more associated with the BRAF V600E alteration. And for the pleomorphic xanthoastrocytoma, the BRAF V600E is more common. For oligodendrogliomas, interestingly, it's more associated, and this is in children actually, with the FGFR alteration. And unlike adults, the 1p19q co-deletion doesn't mean much. So this is one other aspect that really has changed after this new classification came, because the neurosurgeons and our neuropathologists were really seeking the 1p19 co-deletion as a diagnostic marker in oligodendroglioma in children, but not anymore actually. The ganglioglioma is more associated with the V600E, and the desmoplastic infantile astrocytoma and ganglioglioma, again, the BRA V600E. The DNETs in general are associated with the FGFR and less commonly the V600E. Neuronal tumors, the SLC44A1, these are quite rare tumors actually compared to the previous one. However, we do see these patients every now and then. Actually, we do have one of each. The MIB is actually diagnostic for the angiocentric glioma, and the V600E again is present more commonly in plenty with the FGFR. So once you diagnose these patients, that means either after a surgery or after a biopsy you obtain safely, you get to diagnose them pathologically and molecularly if possible. You evaluate these patients according to whatever we have mentioned before. So you look into their neurology, their ophthalmological or visual acuity assessment, and other parameters. And you categorize them into the complete or incomplete categories. So observation here is a mainstay of the treatment, or it's something that neuro-oncologists do quite a lot with pediatric low-grade glioma, so we are quite brave. And we do observe patients with complete resection or asymptomatic incomplete resection. And in patients who are symptomatic, we evaluate them. We look into all the aspects, whether they're syndromic, non-syndromic, and then we prioritize treatment accordingly, according to the age group and so many other factors. And I'm going to mention the indication for treatment in more details a bit later as per the SIOD low-grade glioma guidance. The chemotherapy here is actually advocating for a delay in introduction of radiation in these patients. So radiation is quite morbid. It's nothing like, we don't prefer it for pediatric low-grade glioma. Like here in Oman, we follow them until